Holding the probe at about 45 degrees to the vessel, the Doppler generates an audible sound and the waveform on the screen shows a direction of flow. In a healthy person, the arteries in the ankle have blood flow in the forward and reverse direction. By applying a blood pressure cuff to the ankle and inflating it over systolic pressure, the blood flow is stopped and the sound disappears. The cuff is then deflated slowly, and the point at which the blood flow starts and the sound is heard is the systolic pressure. As stated earlier, the preparation of the patient is really important, because if the patient is not prepared correctly, incorrect readings may be recorded. Let the patient know what you are doing and why. As smoking can affect vascular flow, it is advised that the patient should refrain from smoking for at least 10 minutes prior to the procedure. Make sure that the room in which the examination takes place is not too cold. If the patient is cold, the peripheral circulation shuts down and recording signals may be impossible. The room temperature should be ideally around 22 to 24 degrees. This allows the vessels to dilate and make signal recording much easier. Tight clothing should be removed from both arms and both legs to allow correct placement of the blood pressure cuff and prevent the tourniquet effect. If the patient has a wound on their leg, it should be undressed and covered with a clear film to allow visual assessment of the wound healing status. Most importantly, the patient must be rested in a supine position for 10 to 15 minutes to allow pressures to equalize as much as disease will allow. Tight clothing from around the waist should also be removed for blood pressure measurements. Using the Doppler, first the brachial systolic pressure is determined in both arms. Making sure the patient is relaxed and comfortable, the cuff is placed around the arm. Palpate the brachial artery and then apply gel. Using the Doppler, locate the artery and hold the probe about 45 degrees to the skin. Inflate the cuff until the sound disappears. And then slowly deflate at around 3 mm of mercury per second. The point at which the sound returns is the brachial systolic pressure, which is then recorded. Repeat the procedure on the other arm and use the higher of the two readings in the calculation. If the readings are significantly different, this suggests arterial disease. It is important to remember that the probe needs to be placed onto the patient's skin at an angle of 45 degrees to the vessel being examined. Also, it must be placed where the tip of the probe is pointing toward the heart. In most guidelines, it is stated that a minimum of 2 pressures should be taken from each foot. However, local protocols may state otherwise. The posterior tibial pulse is probably the easiest to locate and hence is often used along with any other artery in the foot. When assessing the dorsalis pedis artery, be mindful that this is absent in 10 to 15% of the population. Then the ankle systolic pressure is determined from both the dorsalis pedis and posterior tibial arteries. The cuff is placed around the leg just above the ankle. Gel is applied and then using the Doppler probe, locate the dorsalis pedis artery and optimize the signal, holding the probe at about 45 degrees to the skin. Keeping the probe still, the cuff is inflated until the sound disappears, and then slowly deflated until the sound returns. This is the ankle systolic pressure and should be recorded. Repeat the procedure for the posterior tibial artery. The higher of the two readings is then used for the ankle brachial index calculation. In this example, the higher pressure from the arms is 150 mm of mercury. The higher pressure from the right leg is 85 millimeters of mercury. To calculate the ABI, divide the higher ankle pressure from each leg by the higher of the arm pressures. ABIs of between 1 and 1.3 signify normal arterial blood flow. Compression therapy may be applied as long as the rest of the holistic assessment agrees. Notably, compression therapy should never be applied purely on the basis of the results of a Doppler ABI assessment. ABIs of 0.8 to 1.0 indicate mild arterial disease. Compression therapy may be applied with caution. In practice, this is usually only done under the supervision of a specialist, clinician, nurse. ABIs of between 0.5 to 0.8 signify significant arterial disease, and compression should not be applied unless recommended by a specialist. If the ABI is below 0.5, this indicates severe arterial disease present, and this patient should be referred urgently to a vascular specialist. ABIs of above 1.3 suggest the presence of arterial calcification, which can be associated with conditions such as diabetes and chronic renal failure. In such cases, the ABI cannot be relied upon to give a true indication of the arterial status of the limb. Hence, an alternative form of arterial assessment, such as waveform analysis or toe pressures, is needed. Venous leg ulcers are usually treated with some form of compression therapy, bandages, hosiery, or intermittent pneumatic compression. ABI measurement should be repeated every 6 to 12 months, unless symptoms change in the interim period. The symptom changes may be observed when bandages are changed, usually on a weekly basis. There are several medical conditions that may affect the accuracy of ABI measurement. Diabetic patients may have associated calcification of their arteries, which could artificially elevate the ABI. Renal patients may also have calcification, but can also have fluctuating blood pressure, which can again affect the accuracy of the ABI. Patients with rheumatoid arthritis can suffer with vasculitis, where the vascular system becomes inflamed and is very painful. If a patient was suffering from this, they would need treatment with antibiotics before attempting an ABI measurement. Arterial sclerosis, hardening of the arteries, of course can make it difficult to compress the arteries, which again can lead to false high readings. Many patients have undiagnosed cardiac arrhythmias, so it's a good idea to manually check their pulse before undertaking an ABI, although you will also hear that the pulse is irregular when you listen to the Doppler signal. In such cases, it is particularly important to deflate the blood pressure cuff slowly to ensure that you don't miss the point of returning blood flow. Peripheral edema may falsely elevate the blood pressure readings. Lipodermatosclerosis, the presence of discolored, hard, fibrotic skin on the lower legs, can also give falsely elevated pressure readings. Importantly, the presence of any of these conditions does not mean that you should not undertake an ABI, but instead suggests that you should view the results with caution and of course also consider them in light of the patient's presenting history and clinical examination findings. If in doubt, then refer to the patient for further investigation. In summary, some of the key points are mentioned here. Here are some more points to be considered. The ability measures the systolic pressures of all 4 limbs simultaneously. This means that there is no need to rest the patient prior to the procedure. There are 4 uniquely designed cuffs which measure systolic blood pressure in a different way. This machine also has the added benefits of an integrated printer for ABI and waveforms, as well as connectivity to a software package for electronic records. The ability can measure ABI in 3 minutes. Because all limb pressures are measured at the same time, there is no need to rest the patient. The patient must be laid as flat as possible. Obviously, for patients with chronic chest problems or cardiac failure, this can be difficult. Be aware that if your patient is not completely flat, this can affect results. Results are printed via the integrated printer. Using the USB port at the back of the unit, results can be transferred to the Dopplex Reporter software package for electronic storage and review. Automatic calculation and display of results means that the procedure can be performed by healthcare support workers, freeing up clinicians for other duties. Several high-quality independent research studies have demonstrated the clinical validity of the ability. Using PVR, pulse volume recording, a waveform is produced which can be visually interpreted to verify the ABI result. Each complex within the waveform represents the phases of one cardiac cycle. So the upstroke represents systole, the downstroke represents diastole, and the dichrotic notch represents reverse blood flow. Here you can see what constitutes a normal PVR. The second figure shows mild PAD. You will note that the dichrotic notch has disappeared in this waveform. The top figure shows moderate PAD, and here you can see that the waveforms have flattened and rounded, and the amplitude is reduced. The bottom figure shows severe PAD, where the waveform has been reduced to an almost flat line. Several research studies have assessed the clinical accuracy of the ability and have demonstrated its clinical validity. It has even been shown to be comparable to duplex ultrasound scanning, which is considered to be the best method of non-invasive assessment for PAD. The ability utilizes plethysmography to measure systolic pressures, and this has been shown to be superior to other automated ABI systems, which normally function on the principle of oscillatometry. Oscillatometry cannot detect low ankle pressures and hence can rarely measure low ABIs. There are several benefits of using the ability, including time saving, reliability, and that the procedure used complies with international guidelines. We will now run through some case studies to illustrate the value of having PVRs as a secondary form of arterial assessment. In the case above, you will notice that the patient has returned high ABIs. They are not within the normal range, 0.8 to 1.3, so they cannot be relied upon to give a true indication of the arterial status of the limbs. However, if we look to the PVRs as a second line of assessment, you can see that the waveforms are completely normal, hence ruling out PAD. In this case, the ABIs are within normal parameters, but if we look at the PVRs, I think that you will agree that the waveforms are most definitely not normal. They are, in fact, suggesting moderate to severe PAD. On the basis of these waveforms, this patient was referred to a vascular surgeon for further investigation and subsequently underwent successful bilateral angioplasty. There are numerous advantages to using an automated ABI system. We have already mentioned in session 1 that the ABI can sometimes be unreliable, and this is primarily due to the presence of arterial calcification. Analysis of Doppler waveforms can provide an alternative form of assessment in such cases. Doppler waveforms are a pictorial version of the Doppler sound that you hear when assessing an artery. As with PVRs discussed in session 1, Doppler waveforms can be visually analyzed to identify arterial insufficiency. Their worth is well recognized in the literature. Indeed, several diabetic organizations, such as the IWGDF, recommend that they should be utilized in conjunction with the ABI in diabetic patients. Studies have shown that Doppler waveforms are better indicators of healing potential than the ABI in diabetics, and furthermore, they are also very reliable indicators of arterial disease. This clip shows normal triphasic Doppler waveforms, which have 3 distinct phases: forward, reverse, forward. This can be heard in stereo with the flow above the line heard in the left channel and flow below the line heard in the right channel. The clip shows biphasic Doppler waveforms. These are usually normal but have lost the third phase, due normally to an aging process. This clip shows abnormal monophasic waveforms which are indicative of PAD. Note the loss of the reverse flow, i.e. no waveform below the zero line. This is clearly an abnormal waveform from the lower limb and should be accompanied with a low ABI, unless medial calcification is present. This clip also shows monophasic waveforms, which are indicative of PAD. Again, note the loss of the reverse flow, i.e. no waveform below the zero line. This is clearly an abnormal waveform from the lower limb and should be accompanied with a low ABI, unless medial calcification is present. This section covers the measurement of toe pressures and the TBI. The toe brachial index, or TBI, is another form of assessment which can be used in patients for whom the ABI may be unreliable. Toe pressures have been used for many years and are recommended by several different organisations, such as the AHA and ESC. They are thought to be particularly useful for those who may be susceptible to arterial calcification, such as diabetes. Digital arteries are generally spared of calcification, so if possible, toe pressures should be taken. Place an appropriate size toe cuff around the base of the big toe. Attach the PPG probe to the tip of the toe using the self-adhesive strip. Inflate the cuff slowly until the pulses disappear. Then deflate the cuff at 3 mm of mercury per second by keeping the white line within the green band. When the trace stops, the first pulse represents the toe pressure. If the first pulse is not visible, then scroll the trace until it aligns with the line. This is the toe systolic pressure and should be recorded. If the toe pressure is less than 30 mm of mercury, the prognosis for healing is poor. If the pressure is greater than 50 mm of mercury, then ulcers have a good chance of healing. If the toe brachial index is less than 0.64, then arterial disease is present. The TBI is calculated in the same way as the ABI, except there is only one pressure for each big toe. So this pressure should be divided by the higher of the brachial pressures. Consideration of absolute toe pressures can also be helpful. For example, a recent meta-analysis, a study which has combined the results of several studies which have investigated a single issue, found that toe pressures of less than 30 mm mercury were more than 3 times greater risk of non-healing and amputation. We would like to acknowledge the following people who have helped us with this presentation: